they can always access. Okay, so maybe we should just go ahead knowing that there'll be probably a lower turnout today. Yeah. Hello, everybody. Okay, everybody's connecting to audio still. Okay. Good afternoon. This is Dr. Wen with Geriatrician with Department of Geriatric Medicine and course director for this ECHO series. So it's always good to see you, and for attendance purposes, we'd like you to enter your name into the chat box as a way of taking attendance. And even if you have a smartphone, you should be able to do that as well. So thanks very much for joining us. Next slide. Oh, actually, John, you need to start the slides if you don't mind. Okay, great. So this is our ECHO series. Next slide. And just wanted to give a nod and a shout out and a thank you for all of our partners here, which include HAH, Mount Pacific United Healthcare, and Aloha Care. That's part of a collaboration with the GWEP program at the Department of Geriatric Medicine. And next slide. Everything we talk about here is going to be confidential and safe. All presentations and case presentations should be HIPAA compliant, and this should be an encouraging and safe learning environment. No question is too small or too insignificant. And a reminder that any case consultations don't create or establish any patient-provider relationships. This is purely for educational and learning purposes. Next slide. Next slide. Oh, the schedule. So this is the schedule. We have our sessions on the second Thursday of each month from 2 to 3 p.m. And this is today's session, Improving the Process with PDSA, Addressing Social Engagement. Next slide. So the main goals of this nursing home series is that we help the nursing facilities apply leadership and quality principles to their challenges in patient care, whether it be for COVID or whether just for improving age-friendly health systems and caring for our frail elders. And so hopefully we'll translate to improve quality measures down the road and hopefully star ratings as well. Next slide. Okay, this is the case presentation template. If you have any cases that you want to share in advance, that would be really great. And so we'll just wanted to let you know that you could download this form and email to Michaela E. Brow at that email. Next slide. And also that we do provide CMEs, and in order to get the CMEs, you need to first register for the session and then complete the evaluation. Just so you know, we are approved for CME credit as well as social work CEUs. Next slide. Oh, okay. And so anyway, so let's just, I'm just thinking maybe since we do have a smaller group today, we could, probably go around and introduce ourselves a little bit. I'll get to the speakers last, but maybe other folks want to go around here. Maybe I'll just call on order of my slide here. Jeanette, do you want to, just a quick, maybe name, profession. Or anybody else? Okay. People are shy. Okay, anyway, I know that there are a few of you out there, some nurses and physicians and administrators, and so I really appreciate your coming. And we have, of course, some of our folks from Mountain Pacific and HAH. Okay, so let me introduce you today. Our speaker today is Mary Erickson, and with her today will be Dana Mitchell. Let me just speak. Mary Erickson, she is coming to us from Mountain Pacific. She is an advanced quality improvement lead for Mountain Pacific, which is a nonprofit health quality improvement organization since 2012. She manages quality improvement initiatives and ensures that healthcare facilities comply with the CMS payment reform quality reporting programs. She assists hospitals and clinics with implementing electronic health records. And before joining Mountain Pacific, she served as the Chief Operating Officer for Pandura Medical Center. She has been working in healthcare since 1998 when she started off as a staff nurse. With over 20 years of experience in risk management and healthcare leadership, she is a valuable member for the Mountain Pacific healthcare team and a great resource for us as well. So we're really glad to have her. I want you to know that she has no conflicts of interest bearing on the subject matter of today's program. And we have Dana Mitchell, which is who just basically joined our the Mountain Pacific team as the nursing home lead for quality for Alaska and Hawaii. So she's going to be an amazing resource for all of us as well going forward. So without further ado, I'm going to let Mary take over.
Okay, thank you, Dr. Nguyen. Can you hear me okay?
Yep.
All right, good deal. Thank you for that introduction. We're happy to be here, and we're happy to be working on this collaborative effort with all of you and your partners. This is important work, and we're always glad to be supporting the nursing homes in the islands. So some of the things that we're going to talk about today are to understand the key elements of the Plan, Do, Study, Act cycle, or the PDSA cycle, use PDSA as a core improvement methodology in the nursing home setting. We're going to walk through some examples and specific cases about how we have applied PDSA cycle to action plans, maybe following root cause analysis. And so you will see where we're kind of playing on or continuing some of the education that you've had recently as part of your ECHO with root cause analysis and all of that. So really trying to go through the whole entire quality improvement process with you as a support, as a reference, and maybe for some of you it's just a refresher, but please feel free to share and ask questions, share examples and stuff along the way as we talk today. So the first question we usually get is when and why do we start a PDSA cycle? So these are some of the reasons. You know, I looked back through your other sessions and it talked about PDSA, or it talked about evaluating processes. And so I just kind of picked out in those situations from your previous sessions where you would start to do PDSA cycles. And these are some of those examples. So if you have a common or infrequent failure, that would be a situation that you would need to use maybe a PDSA cycle to start looking at. One quick reminder on that from that session that I thought was worth mentioning was one person doing something or one person with a failure doesn't necessarily mean a systematic failure has occurred. So making sure that you're addressing systematic failures versus maybe potentially performance issues. So then looking at the process to fix one attribute at a time is really where the PDSA cycles come into play. And we'll talk some more too about PDSA cycles can be very fast. They don't have to be, 1 month long or 6 months long, or there's really not a set of specific rules that you need to follow, but you really can go through a process and fix an attribute at a time over, a month or a couple of months in a systematic way. So we're going to talk about how to do that. This was another example, and I'm not going to go through the whole entire algorithm here, but this was another example from one of your previous sessions, and where PDSA would fit in here is these steps down at the bottom where you are testing and measuring something on a small scale, or you're trying to take something from a small scale to a larger scale. So you've started out with a pilot study and you want to expand that improvement to another area, or maybe you started on one area or one unit of your nursing home and you'd like to, expand it to other areas. You'd want to continue that PDSA cycle as you grow out to those other areas. So that was an example of a time and place when you would want to do PDSA cycles from some of your previous sessions. And session 7 was, there were some improvement questions that you reviewed, and the last 2 bullet items were the items that I felt you could use appropriately a PDSA cycle. So what could you try that would get you closer to success, and what could you try out, I think before the next call, even between project echoes. So it's even feasible to do a PDSA within a week if you have all the right tools lined up and have the volume and the process that you want to evaluate. So then let's talk a little bit about how you use PDSA. So I think one of the first important steps to using PDSA successfully is to find a good tool to help you through that process. So we have a couple of additional tools here that I have quickly pulled up, or that I will quickly pull up, that are available on our website. This is the first one, and we've tried to keep these to 1 page. It's really not intended to be a big, huge, lengthy exercise, but it's intended to just be something that you can use to think through your process with your team, think through how you're going to measure your success and what you're going to do. So in this template, we have your evaluation measurement right at the top, and how are you going to do that? And that's, really to drive home that everything you're doing should be driven by data, even if it's a small process and it's a small process measure, that it should be driven by data. So you can kind of define all of that for yourself here, measure, do a quick measure of current performance, and keep track of that as you go through your PDSA cycle. And again, this is small and brief intentionally, because we want you to take small steps to larger success. So defining, what solution you're going to do, who's going to do it, when is it going to be done, and where is it going to be done? And then what are the specific tasks? And maybe there's only 3 tasks here. If this list gets really long, I would break it up into a couple of different cycles instead of trying to do so many things at once. And part of that is, it's the more things you add to change in a process at the same time, then you don't really know what's working and what was really truly the successful items that resulted in improvement. So it really is valuable to break even a large process improvement project or a large project down into some smaller PDSA cycles. And again, it's really important to spell out with your team and that everybody understands who's responsible for what, when they're going to do it, and where they're going to do it. And I do say where because sometimes people assume things about where something's done. Like maybe you have a medication project and you need to include the medication room in where things are going to happen, in addition to the medication cart, in addition to the residence room, those kinds of things. So really thinking through all of that as you're laying this out. And then how are you going to measure it, which you've kind of defined that up above what your measure is, but how are you going to get that data? And if you're doing cycles that are a week or a month or less than that, you're going to need data that's really fast, that's easily accessible. So don't make the data part the hardest part. Try to keep it simple. There's nothing wrong with keeping track of something on a piece of paper, put a logbook in the med room. Hey, this is our QA track how many times you gave this drug, or, you know, whatever it is, just really quickly, and then somebody collating that. So it doesn't have to be big and elaborate when people talk about data when it comes to these small process measures, because you're really just measuring a step. So whatever you need to do to measure that step quickly and accurately, and compile the results quickly, is really how you should think about data in this type of situation. And then, of course, the do part, implement it. What did you do and who did you engage? So this is really that as you're doing it, you're kind of completing this section. What are you observing? What are your staff observing? What's their feedback? That kind of thing. And some of that plays into the next step of study. So then really, you know, what were the results of the feedback, the end results of the data? What were the successes? Did everything happen that you expected to happen? And if it didn't happen that way, then why didn't it happen that way? You know, those kinds of things. So this is one tool that we have that is available on our website, and I'll also make it available after this presentation. So I wanted to show you one more template that we have available. This one's a little bit more lengthy, but it does spell things out and help you walk through in a similar way the different tasks of a process that you're doing. So the top part is very similar to the last one. It spells out your team. And these are, you know, this is where we're talking about what are the additional tasks, when is it going to be done. So you might even use this one for something that's taking about 6 months, and you can just continue to add to it once one thing is done and you've studied it and are successful, then you go to the next. So this one's just intended to be a little bit longer. So we'll get back to PowerPoint. And then, of course, the IHI has lots and lots of PDSA tools and information for you as well. So really that first step, like I said, just to kind of summarize here, find yourself a tool that works for you, or we put our documents, the ones I showed you, out there in Word, specifically so that if they don't work for you, you can change them. You can take what you want to use and toss the rest, you know, make it your own. The important thing is that it works for you. So this is the whole cycle, you know, and you probably may have seen this before. So that whole plan, do, study, act that we really talked about. And again, I just want to emphasize that there really aren't rules here other than think it through, you know, do your planning, look it over, study from it, learn from what you're doing, and then apply that. And I think where some people get stuck is they go through the plan and the do and the study, but they don't always circle back to the act and start again. So it's making sure that after you've studied your improvement, that you then go through this, you start over, you know, essentially, until you're all the way to where you've improved your outcome metric to where you want your outcomes to be. So you're studying these smaller process steps using a PDSA cycle to get to your larger quality improvement outcome metric. So, you know, medication management, maybe we're trying to reduce adverse drug events in the nursing home. And so you're doing these small steps and you're measuring small steps of the process to get to, you know, reducing adverse drug events or something similar. And this documentation, I did want to highlight this for just a minute, because some people, this is where people also get hung up. Like they'll say, oh yeah, I do PDSAs all the time. We do them all the time. We do them all the time. And I'm like, okay, great. Show me one. Oh, oh, you mean you wanted some documentation about well, we just kind of think it through. And I'm like, no, you know, that PDSA worksheet, post it in the med room if you're working on a project. This is what we're working on. This is what we're doing, why we're doing it. So you can use it for training purposes. It helps also, you know, to give everybody an understanding of what interventions were actually effective. And it documents that, so you have some type of historical record of this is what worked, this is what didn't. Because we also know in quality improvement that some people say, oh, we tried that 10 years ago and it never worked and I'm never trying it again. And it's like, okay, but where's your documentation and what parts of it didn't work? And that's what I always try to get to with people is what parts of it didn't work that we need to change and maybe try something again. So it helps with that historical piece. And then, of course, we all know that state surveyors and CMS love to see our documentation on these projects. And the other thing that I say about that documentation is you're doing the work, you're doing the projects, you're doing the improvements, your staff are working hard. Get it documented so that you can take credit for that, because that's important stuff to show that you are doing on a regular basis. And both of those templates hopefully are easy enough to utilize that it wouldn't be too burdensome. It doesn't have to be big, long, huge documentation. It can be very simple and straightforward. And both of those documents have been used by organizations with surveys, even by my own self personally. So I know that, you know, it doesn't have to be this big elaborate scheme. So, well, that being said, I'm going to turn it over to Dana Mitchell, who I'm so excited we have found Dana in Alaska. She joined us recently and comes to us with some great experience in quality improvement. So Dana, go ahead. She's going to talk to you about some actual examples that she's worked.
Yeah, thanks, Mary. Can everybody hear me okay? Great. Dr. Wen, about how much time do I have?
Oh, I don't know, about 10 minutes or so. And then,
great.
you know, well,
Okay.
you know, of course, if there's questions in between, of course, that's fine. We just want this to jumpstart the conversations.
Sure. I just don't want to cut into your time later on, so I can keep an eye. Yeah, so greetings from Alaska, where we just had about 2 feet of snow last night. So we're longing for a little bit of sunshine. I am going to give a couple of case studies from 2 different skilled nursing facilities up here in Anchorage. The first one, I'm going to talk about alarms. And then the second one will be experience of care and the dining experience. So the first one comes from a 50-bed transitional care center that's focused on mostly short stay and rehab. Folks, their goal is to keep people moving through to the, you know, up to the next level of care, whether that's to long-term care or to home or to an ALF or whatever. And this one took place a couple of years ago. I was a quality director at this facility, and in our follow-up committee, I noticed that they would meet weekly and review every fall that had occurred during that past week, try to get to a root cause analysis, try to do improvements on assessments, try to keep our residents safe. And I noticed that on almost every fall review, there would be a resident removed the alarm and the alarm was put back on. And I was like, what is going on? Why who in their right mind would say, well, they don't want it on, but we're just going to put it back on anyway. And I think hopefully we all know that alarms don't prevent falls, especially if you're dealing with cognitively impaired folks or dementia. It really just alerts you to the fact that somebody is now on the ground. And so they're not a best practice, but for some reason we were putting them on. So after some root cause analysis, we tried doing education. You know, we were meeting weekly, so we said, okay, what's going on? We need to let folks know that this is not an appropriate intervention because it's not going to reduce their falls. And if, you know, education is never your best action necessarily. So after root cause analysis, we figured out that upon admission, the admissions nurses were automatically ordering an alarm to be placed. So everyone who came into the building would get a fall alarm, regardless of their risk for falls or injury. And so at that point, we had probably around 45 residents and probably close to 60 alarms. So there were people with multiple alarms. They would have one on their chair, they'd have one on their bed, they might have one, you know, in the door frame. so that was our first, the root cause analysis identified at what point we wanted to focus. We collected our data and saw that sort of outrageous number of alarms that we had on the floor. And you can imagine how noisy it was. So Mary talking about med pass, when you're needing to focus and you have alarms going off right and left, it was going to have rippling effects throughout the facility. So we started really small, and I think that's kind of an important piece to doing a PDSA, is it shouldn't be intimidating. It should be easy, like Mary said. Sometimes you've got to think things through to figure out, where's my data coming from? Am I collecting the right data? Where do I want to start? But you don't want it to be intimidating. Don't eat the elephant an entire time. Take one little bite. And so what we did was we said, why don't we just take a week's worth of admissions and don't put a single alarm on those folks. And we can leave all the rest of them in place, but we're just going to start without putting any on our new admissions. And then the nurse manager, who was really a champion of this, she's actually the one that said, you know what, they're all coming to us with alarms on. And so she was bought in. She really championed it. So she would then assess each person for the first several days once they get comfortable, and ensure that they're not falling. And we suspected that wasn't going to be the case because we're actually removing them. But we wanted her to make sure she had the full authority to place them back on if she wanted to. So everybody felt like it was not intimidating, it wasn't scary. We're just going to take this one step. And of course, we found that there was no increase in falls. We gradually, week to week, began pulling alarms. And so within a matter of about a month to 6 weeks, we're down to no alarms in the facility and no increase in falls or injuries. And a huge increase in staff satisfaction because it was now quiet, people could sleep, it wasn't interrupting med passes, and they've been able to maintain that. They will occasionally put something like a room alarm on, a motion sensor in the door, but that's more to alert the staff that somebody is getting up and wandering, and they're not expecting that to be a fall intervention. And they've never gone back. So it felt in hindsight like it was just so easy, and it was just that one step of where is this coming from, and let's test just for a short period of time and see what happens. And you can even start a PDSA on, one nurse with one patient for one day, depending on what you're testing, and expand it to, okay, did that work or didn't it work? Let's tweak it. Let's try 2 days and 2 nurses, and so on. So that one, I was kind of astonished at how easy it was and how they've been able to maintain it. There was never any backslide. And that's one thing you need to incorporate into your plan, is periodically checking back in and making sure that you don't backslide, because old habits die hard, and sometimes it's easier to just do what we're familiar with. So before I move on, does anybody have any questions or thought or comments on that, or shall I just go ahead and move on to my next case? All right.
Okay.
So this next case is in a 96-bed long-term care facility. It's a facility that's divided into 8 cottages that have 12 residents each. And it was built not necessarily with the Eden greenhouse model, but similar. It's got I don't know if folks are familiar with that, but it's creating really a home for folks as opposed to a nursing kind of institutional feel. So these cottages are built with kind of a fireplace and what they call a hearth living room area, if you will, and an open kitchen. And then the rooms are all around the perimeter of the cottage. So the kitchen is really kind of like in your own home, the central focus of the cottages. And it sets itself up for some great PDSAs because you already have your distinct groups. So you can trial pretty much anything in one cottage. And we've done that many times. Say, let's just try it in this cottage, see how things work, and then we can expand to 2, and then to 4, and then to all 8. And so one example of doing that was our resident satisfaction in the dining experience. We had a great dietary team who was really working hard and made incredible improvements in kind of the life safety aspect of dietary, making sure all your dates were checked. They never get cited anymore for anything being out of date or not being, have an open by or use by date on it. But the resident satisfaction with meals was decreasing. We use an instrument called My Interview. I don't know if folks are familiar with that, but it's they're now owned by one of the big survey companies now. Their name is escaping me, but it's only surveyed once a year. And we had noticed, we were kind of used to cruising along, and then there was a drop. So this was after moving into this new model. So our dietary manager really took to heart resident-centered care. And she determined that they were going to have resident-centered meals. So they started with one cottage and spent several weeks working in that cottage to adapt a menu plan that incorporated what the people in that cottage wanted to eat. Not just what was set out for the facility for that month, but they all had input. If, nobody there eats pork, you're not putting pork on it. If, people don't like mushrooms, you don't have mushrooms. If there are cultural things that people want, she makes sure those are on the menu. And it took a lot of work to revamp 4 weeks worth of menus to adapt it to one cottage while still maintaining the same menus for all the other 7. But they managed it for that one, kind of got comfortable using that one, tweaking menus as they needed to, kind of getting the feel for the resident feedback. The cook works in that cottage, obviously in that kitchen. There's not a main kitchen for this setup. So they're there right in the center of the cottage. So they're getting instant feedback on how meals are, instant feedback on, what folks did or didn't like, what they wanted added. And so they got rolling with that, and residents would bring it back to the resident council and say, we love this, thank you, this has made all the difference. So then they were able to expand cottage by cottage. And it took them lots of time because you're meeting with 12 distinct individuals every time to get what they want to have on their own menus. But they made it through all 8 cottages over the course of, I want to say, is about 6 months probably. And on that following year's satisfaction survey, their scores improved by about 10 points. And they've been able to maintain that. And it's had some, not only improving the dining experience for the residents and their satisfaction with their meals, but we've actually been able to use that, like Mary said, keep this documented for your survey. We had a citation about somebody who said they wanted like black-eyed peas or something, and we were cited for not providing the meals that they wanted, and we went back and said, what are you talking about? We have the menu for that cottage right here, and on this day there's collards and black-eyed peas, and she gets that whenever she wants, and we're able to produce that and get that tag removed. So they can have benefits beyond what you immediately set out to achieve, but they're so worth taking that step and defining the small population that you want to work on, defining clearly what you want to do with them, and always checking back to see what can we tweak, what can we do a little differently. If it had fallen apart in that first cottage, we would have continued to work to figure out where did we go wrong, take it back to the residents and try again. And having that set up really, like I said, helps so much to have already distinct populations of folks, but whether you have a wing, a home, it's well worth figuring out your population and taking those steps.
That's great. Thanks, Dana. Those are great examples. Nice work. Kudos to those organizations for taking that on. But
Yeah.
okay, Dr. Nguyen, we that was our presentation for today. So you have some good support here listed in Hawaii. Dana is your nursing home contact, so you'll be seeing more of her. And then, of course, we have Mark and Maggie, who've been supporting Hawaii for several years and doing a great job there. So
Great.
feel free to reach out if you have any questions. I'll turn it over back to you.
Okay, great. Thank you. Yeah, so we wanted to, have the opportunity to discuss some of the challenges here in Hawaii, and maybe we can, share cases, and then bounce things off, and we can all share ideas about our experiences. And so, one of the thoughts I had was, what are we dealing with right now, right? And I think the thing on people's minds at this point is visitation during COVID. Now, especially since we just got the CDC guidelines that just came out. And we asked around, and I think Aloha Nursing. So Vanessa Bruns, she volunteered to submit a case. And so we're going to ask her to share what she's done so far. We really, really appreciate that. And then, we can open that up for questions from the audience and ideas, further ideas. Thanks so much, Vanessa.
Hi. Do you have questions, or did you just want me to talk?
Well, I was wondering if you could share what your process that you've been doing at Aloha Nursing Rehab, and maybe we can, any challenges that you have, and how we might structure how you are structuring the PDSA cycle for that.
Okay. So what we've done and what we've had in place is that we have one phone number that people call to schedule their visitations. That is working really well. The manpower to be able to monitor, that's where we're having the issue. It's just not enough manpower to offer multiple visitations from happening. So one of the things is the CMP project came out where we could buy another divider and a tent. So that gave us the ability to offer more than one door visitations. We also have some guidelines for them to follow, which goes with the core values, making sure that there's no touching, there's 6-foot distancing, wearing of masks and such. And one of the problems that we were encountering is that families would take their masks down and want to talk to them or reach around the barrier. So we had to make sure that they were monitored 100% of the time. And we were able to figure out who exactly followed the rules and who didn't. So we made sure that that monitoring was in place for certain folks. Now that the new sorry about that telephone ringing. Now that the new guidelines are out and supervision doesn't have to be there, that's going to pose more, because a lot of families do follow the CMS website, and they're going to start asking, we want in, we want more visits. So right now we've been talking, we met last night, we met today to talk about that, and how many visitations we're going to allow. We've increased the number of visitors that are going to be coming in, because that was another issue that we had, where we were following the state of Hawaii guidelines of how many people can gather at one time in that tier. And now that tier we've moved up a tier, and now there can be 10 visitors or 10 people gathering. We are not able to accommodate that with the space that we have. So it's working with the families to say, okay, you can have more than 5 people visiting, but the extra people are going to have to stay in the vehicle, and you guys are going to have to take turns. And that's the best way that we could do it, versus having a bunch of people out on the lanai and not able to 6-foot distance between everybody. And we've had one family where they just could not adhere to the guidelines, and we told them they cannot visit. You can do the virtual visits, but no in-person visits. Any other questions? And it's making sure staff adhere to the guidelines as well, and they're comfortable enough telling the families, okay, no, you got to keep your mask on.
Yeah. So it sounds like you've had a lot of challenges implemented. You've tried this many times,
Yes.
and you've had a few iterations as we go along. And it looks like now you're perfectly poised to take it to the next level.
Yeah.
Yeah. So, yeah. So what's the proposed plan? How do we walk through the PDSA of expanding this? What do you think?
Well, as we did as a team, the little visitation committee team, we went through the new guidelines that CMS just put out, and we looked at everything that was the same, and then the areas that are different. So we're going to this time allow more visitors to come in and visit. They won't have the plexiglass in between them, but they're going to have a table. So they can still put distancing, but have the table as the barrier between them. And the barrier we're going to use because it is big enough, the lanai is actually big enough that we could potentially accommodate 2 visitations at the same time and have the barrier between the 2 visitations. And as for in-facility visitation, and we're expanding the time too. We were limiting it to 30 minutes for each visit to accommodate everybody that wants to do a visit. So now we're going to do 45-minute visits outside and 1-hour visits on the inside, and open it up to families that can help during mealtime and help feed the residents, because some residents do take at least an hour to consume their meals, which is going to be extremely helpful for the staff at this point in time, because they didn't have the family who did this before, and now it's all on them. Now we can open it up and have the family come in and help feed the residents, which is going to be great. Yeah. And no monitoring of certain people. So, but some people will have to continue to monitor. Okay. Sorry, I keep my monitors that way. I have 2 screens. The camera's here and the faces are here.
Thank you. Thank you so much. Those are great ideas. I don't know if anybody else in our the participants want to chime in of their thoughts, questions, ideas, and even Dana, if you have any ideas or suggestions.
And if we're not on the right path, let us know. If you think if I read something wrong or we read something wrong, let me know.
It's just so exciting that it finally came out. They did say this morning on a CMS call that that they understand the need for physical touch and the need to, hug your loved one and come see your loved one, and that it sounds like the way I'm interpreting things is that if your resident is vaccinated, then I think you're really protected as far as allowing, closer contact. And they're still saying as long as they can still follow mask and hand hygiene and all that kind of thing. But it really sounds like they're acknowledging the need for that, which I know nursing homes are saying, well, it's about time. So it sounds like you're on the right track. I mean, they to me, I'm interpreting as really they're saying, do it now, do it any time of day, try to reinforce your infection control practices, but let people in. So I don't know, how the state of Hawaii has been interpreting the regs and what your state surveyors do. Our state has tended to be pretty conservative and more strict than CMS guidance in terms of surveillance testing and that kind of thing. But the state is saying, yeah, do what CMS says for us. So I think, you don't want to open the floodgates. So you want to be thoughtful about, that you don't have 100 different family members standing outside your door at 6 a.m. But it sounds like you guys have a pretty good handle on how to do that.
We're still going to be scheduling them so that we can still handle the flow until they do open it up entirely. And the other thing that we are going to do is, I know it's not a requirement to COVID test them, but we are going to ask them if they're willing to do it, because we have the supply, and some of the supply is due to expire, so might as well use it.
Yeah, absolutely. Absolutely. And I suspect a lot of them will welcome a test, but yeah, we can't require it. So.
Yeah, I really I think it's really tempting for to sort of bow to family pressure and open the floodgates, but I think it is wise to open it a little bit at a time until your processes are catching up with your capacity. So I like your staged approach.
And I think that inviting them in at mealtime is a terrific idea, and that is something that you could easily PDSA. Say we're going to do these folks for one meal and just see, can we keep a handle on it? Are they assisting safely and that sort of a thing before you expand that? That would be a pretty easy test of change.
I'm just curious, I just have a question, and if I might ask, what kinds of things did you learn from COVID, or different practices, even around visitation, or not just infection control? A lot of that, changed, but just kind of more generally speaking, and even with the social aspect of it, what kinds of things are you going to continue to do, like long-term, like at risk of saying new normal? Like, what kinds of things do you see yourselves continuing to do long-term that you found beneficial during COVID from a social perspective? Like, for example, are you going to continue more virtual visits, like with families that are far away, if that was new? I'm just curious, because that's kind of, we're seeing some of that a lot of some of those things are very much going to continue, more so because we have families that live far distances from residents, and so I just was kind of curious what people are going to continue doing that they found that worked okay once they got through the immediate crisis.
For Aloha Nursing, I haven't even ventured that far yet. Just kind of working on the here and now, but
don't hold it against you.
Yeah. Because a lot of family members do live on the mainland, and just telephone calls and such, and if you have hearing deficit, it doesn't make for a good conversation. And then yeah, I haven't even thought about it. But
I'm really hoping that I'm sorry. I didn't mean to talk over you. I'm sorry, Vanessa. I'm really hoping, and I know you are opening this up to the folks in the homes, but I'm really hoping that telemedicine and telepsych continue to be supported and funded. I don't know about in Hawaii, but we here have a real dearth of psychiatric practitioners, especially when you're talking geropsych. And so the few that do it, to be able to remain in one place and still be able to see people. One of them has started doing group visits that also sort of fills a social need in many ways for the residents. I think that'll be huge, and not having to transport people out for things like post-op visits and things like that. Because anytime you move somebody out of your home, there's a risk, and you're sending staff with them. And I think I'm really hoping that stays. Just becomes a normal part of practicing medicine.
Great, thanks. Yeah, so I'm just kind of curious if any other facilities on the call here have any other experiences they want to share with visitation, any challenges or strategies we think might want to try going forwards.
This is Vanessa again. I think one of the challenges that we're going to see is some of the families that are just going to come up to the door. They're going to knock on the door and want to make a visit right then and there. And we're trying to figure out how to nicely work with them, say you can't visit right now, this is what you need to do, this is the plan. Especially after so I'm going to create a letter, post on our website, and then through our medical records system, we can send emails and text messages to families with the letter to say, hey, look at our website for a new updated letter. But some people aren't going to read it, and they're just going to show up at the door.
Mm. Absolutely. Actually, I was just thinking that too. I said, I think this family education piece is going to be kind of crucial for this going forward. I mean, staff education is one thing, but I think family and caregiver education is a whole other animal. That's a good strategy for those who have the email, text, and website updates. Any other facilities have stuff how they do this? Anybody? Do you write letters and just send them via snail mail? Oh, okay. Repeat the question. Yeah. Oh, okay. Yeah. So I was wondering about, family education, about the new visitation guidelines and things like that. How are we going to communicate about that with families? Any strategies that we have? Anyone using social media to get the education out? Anybody?
Hey, Dr. Wen, this is Kevin Wu from Manoa Cottage.
Yeah.
Yeah, we mainly use social media to kind of showcase our activities and things like that. But to educate family, we may kind of send out a letter or have our social services maybe talk to them one-on-one. We're a little bit smaller facility, so I think we could do a little bit more the one-on-one approach.
Mm-hmm. Or maybe perhaps do both, right? Have the letter go out and then follow it up with a one-on-one and a website and social media, probably multi-channel. Facebook. Okay. And Joy says, our visitation policy is on our website. Letters were also sent to the immediate family. Great. Yeah. Otherwise, we'll have chaos, right? Knocking on the door. Are you prioritizing certain residents as part of your PDSA cycle? Anybody planning to do that? I think Vanessa's going to prioritize people who are going to be feeders, right? Have assistance feeding, it sounds like. Anybody else? Okay, any other situations that we have here? I know some of you are in hospice and others are in assisted living, other experiences with regards to the PDSA ideas. Okay. Well, anyway, thanks everybody for sharing. Oh, let's see. Oh, please remember to submit your evaluations in order to get your CME and CE credits. The The link is right in the chat box, and all you have to do is click on that, and then that should take you to the evaluation page. And so that's pretty easy. So don't forget to get your CMEs for joining us. And next month, we will be talking about adherence monitoring and data element. It's sort of that piece that Vanessa was referring to about, like, how supervising compliance to certain things and how can we best do that. So I ask you to think about those things over the next several weeks. And we could talk about how we do that in each of our facilities. Okay, so hope to see you then. Along with more of your friends, please make sure. I know this is a particularly bad time today, given that there was another webinar going on today, and yesterday we had our other HRQ Echo. So I know a lot of folks were not able to attend, but you let your staff and your other friends know that this is recorded, and they can watch it later on. And hopefully we'll be having you attend more of these in the future. And also keep in mind that Dana Mitchell will be joining us in the future sessions, and she can be a really great resource for quality improvement for all of our challenges. Thank you.
Thank you.
Thank
Thanks
you.
so much.